I am Grady Culhane in the CapeCod.com News Center, joined today by a special guest from Cape Cod Healthcare for Breast Cancer Awareness Month. Do you mind introducing yourself for our listeners?
Hi, Grady. I'm Dr. Jill Oxley. I'm a breast surgeon at Cape Cod Hospital and the Director of Breast Services for Cape Cod Healthcare.
All right, awesome. You are a returning face from previous coverage that we've done for that, so it's great to see you again in studio especially. Hope things have been well over this past year for you. We have a lot that I want to tackle before we can wrap up this conversation. A lot of information, some changes that have happened in breast cancer awareness. But starting off, do you mind telling us about who can expect to be impacted by breast cancer? How many people does it impact every year on both like a small scale but also on the nationwide scale?
Sure. So breast cancer continues to be the most commonly diagnosed cancer in the U.S., not just women, but in the U.S. overall. So for this year, the American Cancer Society estimates that there will be 310,720 cases of breast cancer diagnosed in the U.S. and another 56,500 cases of non-invasive breast cancer, or DCIS. And then there will also be estimated 42,250 deaths from breast cancer this year. And that is the second leading cause of cancer death in women, behind lung.
Okay. Yeah, so it's definitely going to impact a ton of people, unfortunately, this year. It can. Should men also be concerned with breast cancer?
I wouldn't say concerned, but aware. About 1% of breast cancers do occur in men. So those same estimates for this year would be almost 2,800 cases and over 500 deaths. And then just to kind of bring the numbers a little bit closer to home, when we talk about incidence rates, the National Cancer Institute, or SEER data, publishes most recent 5-year data. And so the U.S. rates are a little over 129 cases per 100,000 women. Massachusetts does continue to be one of the higher states at 136 cases per 100,000, but we've actually fallen to number 13 overall.
Oh.
But even within Massachusetts, though, Barnstable remains higher than average. This year, this most recent year's data, we're number 3 behind Nantucket and Norfolk County this time. But then in terms of really locally for Cape Cod Hospital, in 2022, which is the most recent year of complete data, there were 403 patients diagnosed and or treated for breast cancer at Cape Cod Hospital. 401 of them were women and only 2 were men. So again, men don't need to be concerned but aware. And there are some factors that can increase a man's risk of getting breast cancer as well, especially if there's a family history, if there's a gene mutation, if they received radiation to the chest, if they have taken estrogen, or if they have any disease conditions that can increase estrogen levels.
All right. And we'll talk a little bit more about some of the possible family impacts and stuff later as well. But I want to ask about one of the key messages from Cape Cod Healthcare is early detection. Do you mind talking a little bit more about why that's so important?
Sure. Well, early detection means that a cancer is found at the earliest possible stages. And the earlier a cancer is staged, the better the prognosis, the better the outcomes. So, for example, a stage 1 breast cancer, which is going to be limited to the breast, has 5-year survival greater than 99%. Stage 2 is still going to be 93%. Stage 3 goes down to 79%, but then stage 4, when cancer has spread to distant body parts beyond the breast and the lymph nodes in the area, that's down to 29%.
All right.
And so cancers that are detected on screening tend to be earlier stage, but they're also better behaved than cancers that appear between routine screening, and also in cancers that are detected in women who don't have routine screening mammograms.
All right. I also want to ask a bit more about what detection is available in terms of the services that you guys offer at Cape Cod Healthcare. Can you elaborate on maybe 3D mammography and some of the other techniques?
Sure. So mammography continues to be the gold standard for breast cancer screening. In fact, mammograms are the only test shown to decrease deaths from breast cancer. There have been more than 9 randomized controlled trials that show that benefit. Annual screening from age 40 to 84 can reduce the risk of dying from breast cancer by about 40%. And 3D mammography, or digital breast tomosynthesis, is what we have across Cape Cod Healthcare facilities. That has been shown to detect more cancers and decrease the recall rates than the previous 2D mammography. And so 3D mammography can also be especially helpful in women who have dense breast tissue. And so Massachusetts has required reporting of breast density since 2015. It's now mandatory for all states. But breast density is basically broken down into 4 categories: A, B, C, and D. A being the least dense, 4 being the most, D being the most dense. And basically half of U.S. women have dense breasts and half don't. And so for 3D mammography, it can be especially helpful in dense breast tissue. But then women with dense breast tissue can also potentially benefit from supplemental screening, for example, with an MRI. And then other women who have other risk factors can benefit from MRI screening as well.
Mm-hmm. How often should women be getting checked in terms of mammography?
So there are different guidelines out there, and Cape Cod Healthcare follows the guidelines of the American College of Radiology, Society of Breast Imaging, American Society of Breast Surgeons, National Comprehensive Cancer Network, and these guidelines recommend starting screening at age 40. Previously, the U.S. Preventive Services Task Force had recommended not starting until age 50, but earlier this year they actually updated their guidelines. Recent data has shown that the incidence rate of breast cancer is actually higher in women under 50 than over 50, the rate of increase. And so they actually lowered their guidelines to 40, but unfortunately they still recommend only getting a mammogram every other year. So again, the guidelines we follow are consistent with most other major organizations, and that is annual screening starting at 40. And the task force says stop at 74, but we recommend continuing as long as a woman is in good health or her life expectancy is about 10 years. And to kind of put that in perspective, the average U.S. woman who is 78 years old has a life expectancy of 10.2 years.
All right. Now, as well, we have self-examination that I wanted to ask a little bit more about, and basically how often and how can people be doing that?
So the term breast self-exam actually has fallen out of favor. A lot of organizations don't recommend breast self-exams at all, the idea being that that was some sort of regimented technique to detect breast cancer. But what that's really been replaced with is what's called breast awareness. And so every woman should know what her breasts look and feel like. And that can be every month. It can be every other month. It doesn't have to be as regimented. But the idea is to look at the breasts in a mirror, see if there's any changes in the skin, and then feel for any lumps, any nipple discharge, any focal areas of pain, so that you can let one of your healthcare providers know. And then a clinical breast exam is recommended starting at age 25.
All right, awesome. What is some of the how do you know some of your risk for cancer to begin with? What are some of the things that can be factored into that in someone trying to judge whether or not they're an at-risk group?
Sure. So I said that the guidelines for screening starting at 40 and then annually were for women who are at average risk. But women who are at above average risk can benefit from additional screening. And so that can include MRIs, and the typical high-risk screening schedule would be an annual mammogram and annual MRI, spaced 6 months apart. But when to start screening depends also on why someone is at increased risk. And so if someone has a high risk due to a genetic mutation, for example, she can start MRI screening as young as 25. We can start mammography screening as young as age 30. So it's really important that every woman have a risk assessment by the time or at age 25 or no later than age 30.
All right. What about family history? Is that's something that might be a bit easier for some people to kind of judge, but can you elaborate on that plays in? As well, I actually want to ask about there's genetic testing that you guys offer as well too. So I was kind of wondering, with family history and the genetic testing you guys offer, can you get a more comprehensive approach that way?
Sure. So there's different factors involved. So after being female, the next highest risk factor for breast cancer is advancing age. Then there's other factors, especially family history. Having a first or second degree relative with breast cancer is a risk factor. Other things we can't control, like race, ethnicity, social determinants of health. Other factors that play a role have to do with reproductive history. So younger age at the onset of menstruation, late age of menopause, no pregnancies or older age at first pregnancy, using combined hormone replacement therapy. These are all risk factors, along with certain types of breast biopsies and then having dense breast tissue after menopause. Genetic testing, on the other hand, has a different set of issues. So gene mutations currently still only account for about 5 to 10% of breast cancer diagnoses. But the idea is if we can find people who are at high risk, either for genetic risk, familial risk, before they develop cancer, that gives us the opportunity to intervene. So we can intervene with these more aggressive screening regimens. And then for the higher risk individuals, they may be candidates for risk-reducing medications or even risk-reducing surgeries. And so we do recommend that anyone who has a diagnosis of breast cancer, either current or past, at least be offered genetic testing. But then there are other groups that are recommended to have genetic testing as well. And so that would be if a woman was diagnosed with breast cancer under the age of 50, if she is diagnosed with a triple negative breast cancer, if she has a type of breast cancer called lobular and either a personal or family history of gastric cancer, if there's a man with breast cancer, anyone who's Ashkenazi Jewish, or if someone is diagnosed with multiple breast cancers at the same time. But then genetic testing is also recommended if someone is diagnosed with breast cancer and has a close relative who is diagnosed with young breast cancer or male breast cancer, ovarian cancer, pancreatic cancer, advanced or metastatic prostate cancer, or if there are more than 3 relatives on one side of the family with breast or prostate cancer. But even somebody who hasn't had breast cancer or any cancer can potentially be a candidate for genetic testing if they have a close relative who would have met those criteria for testing. And again, the idea is to find people who have increased risk for cancer before they develop cancer when we can.
Mm-hmm. When it comes to breast cancer, are there certain lifestyle decisions that might factor into whether or not they are at higher risk? And if so, is there anything that can be done about that?
So we obviously can't control our family history, but there are some lifestyle factors that play a role. So having a high body mass index or being overweight, alcohol consumption, smoking, and then using combination hormone replacement therapy, those are all risk factors. But fortunately, there are some things we can do about that as well. So getting regular exercise, maintaining a healthy weight, eating a diet high in fruits and vegetables, quitting smoking, limiting alcohol, or for the higher risk patients, taking the risk-reducing medications or risk-reducing surgeries. Also, breastfeeding is associated with a decreased risk, as is going through menopause prior to age 45.
Mm-hmm. Oh, very interesting. If someone is in that high risk categories that we've already discussed and the various ways that you can be included in that demographic, what are the next steps for that individual who might be a patient with you guys?
So all patients who are seen in our clinic for not a cancer diagnosis are going to be given a risk assessment. If they see myself, our other breast surgeon, or our nurse practitioner, we're all going to do a breast assessment. But other patients, for example, might have a number that appears on their mammogram report saying that they're at high risk for breast cancer, or they're concerned about their family history or things like that. So if someone is identified as being high risk from family history, again, we can calculate these risk scores. And someone who is determined to have a lifetime risk of breast cancer greater than 20% is considered high risk. And so when someone comes for a risk assessment, we're going to take a very detailed personal and family history. We'll do a clinical breast exam, and then come up with most appropriate recommendations for this patient, whether it's more aggressive screening or potentially genetic testing, along with the recommendations for follow-up clinical breast exams.
All right. And if there is a breast cancer diagnosis that is confirmed in a patient, do you mind telling us a little bit about the next steps and what they can expect?
So there's many parts to breast cancer treatment, so we have a team approach to breast care. As a surgeon, we're usually going to be the first physician that the patient meets with after she's had her cancer diagnosis, or sometimes we are the ones to provide the diagnosis ourselves. But we have a multidisciplinary or team approach. All of our newly diagnosed breast cancer patients are presented at a weekly meeting, and that meeting has representatives from surgery, both breast surgery and plastic surgery, radiology, pathology, medical oncology, radiation oncology, research, social work, so a really comprehensive group, along with our patient navigators. And then all of our newly diagnosed cancer patients will meet with our certified breast patient navigator, and she will help facilitate anything else that needs to be done at the time of diagnosis, say if the patient needs additional imaging or referrals. And then she'll also schedule surgery and coordinate the oncology consultations afterwards.
All right. Are there some other resources that you want to highlight for us while we're still here for people who are particularly diagnosed with breast cancer in terms of other services you guys provide?
Sure. So newly diagnosed breast cancer patients, along with other cancer types, can benefit from a lot of support systems through Cape Cod Healthcare and others. There are breast cancer support groups at the Cuda Women's Center. Cape Cod Healthcare collaborates with the Cape Wellness Collaborative in terms of having support groups for both cancer patients and their caregivers, and also complementary integrative therapies. Cape Cod Healthcare also has the Living Fit for You Cancer Wellness Program, also includes the Bone Fit program, We have a lymphedema prevention program, and then what we like to call breast cancer rehab, which is occupational therapists and physical therapists who are specially trained in all of the issues that go along with breast cancer surgery beyond lymphedema.
All right. Now, for people who might be interested in learning more, can you talk about kind of like first steps of where they can go, if there's like any kind of online or any kind of campaigns you guys are doing that you want to highlight for our listeners while we have you?
Well, unfortunately, since it's at the end of the month, most of the in-person events have passed, but online, there's a lot of information resources available. So I would direct people to www.capecodhealth.org/breast-care for a variety of resources, including the ability to self-schedule a mammogram through the MyChart patient portal and take an online risk assessment.
All right. Thank you very much, Doctor, for joining me for this conversation. Is there anything else you wanted to highlight for our listeners while I still have you?
No, thanks for having me.
All right. Thank you very much again. Well, I'm sure we'll look forward to have this conversation again next year to highlight more of the great services you guys provide. But thank you again for this conversation.
Thank you very much.
I'm Grady Culhane, and thank you for listening.